1.2 million people have died from the virus. Governments the world over are still trying to tweak policy to make sure we've learned something from it. And we got a little more insight from Johns Hopkins infectious disease expert Dr. Amesh Adalja to talk all about it. Dr. Adalja, good to see you. Thanks for joining us. First time in person, too.
Yeah, thanks for having me.
And what's interesting is 4 years ago, we would not be having these conversations as close as we were. We would be doing it through Zoom. A lot has changed in terms of how we've approached COVID. It is still a threat, but we've really, by and large, gone on with our normal lives.
Right. If you think about the fact that we're doing this in person, that really is a testament to how far we've come in 4 years. Remember, this was a virus that wasn't even known to humans before December 31st, 2019. And now we've got vaccines, home tests, antivirals, and we've had a major pandemic where over 1 million people have died in the United States. But now we're sort of getting to a point where this is a much more manageable infection.
So as we see, it is still a threat. It is still, for many people, a serious concern. I was on a flight a couple of weeks ago. People are still masking up, and we saw a bit of a flare-up too. But the COVID that we knew, as many viruses have changed, the virus that we knew 4 years ago is certainly far from what we see right now.
In the sense that we've got a lot of immunity in the population, lots of tools that make it something that is manageable. The virus can still kill people. It can still hospitalize individuals. But what's happened now is it's become something that we have more tools for than any other respiratory virus. And we've got people that have now become risk acclimatized. They learned how to risk calculate. And each person's risk tolerance is going to be different. Some people may still wear masks, some people may not. But that's kind of what happens when you have an endemic respiratory infection, is that each person decides how much risk is acceptable to them. And I think that's really great, because in the very beginning, no amount of risk was acceptable to most people, and we had multiple things shut down. We had hospitals being crushed. All of that is sort of in the past and not likely to occur ever again with this virus.
Do you agree with the guidance that came down recently, where we pretty much put COVID on the level of what the flu would be, it seems?
I do agree with that guidance, and I think it really speaks to how far we've come. And you have to think about, there was a lot of controversy over that guidance, but states like California and Oregon had already did it. Almost every other country, including Canada, had done it with no untoward effects. And I think that really speaks to the fact that we want something that's simple, that people are going to follow, that keeps them away when they're the most contagious, but also kind of weighs the risk-benefit of keeping people out of the workforce, doing things that maybe don't make as much sense when you've got a disease that has less mortality, less pressure on the health system than it once did.
How has this changed the way that you in the health profession approach your job? I mean, clearly this has been a once-in-a-lifetime experience for all of us. So what has changed and what has stayed the same?
I think that hospitals are pretty much back to normal. There's a lot of catch-up going on, because what happened was many hospitals suspended what were called elective procedures. Elective doesn't mean cosmetic surgery. It means you've got some flexibility in timing, and now there's a lot of catch-up going on that way. Hospitals have gotten much more serious about respiratory viruses. Now you see some hospitals will go from masking to no masking based on local metrics. People are much better with isolation in hospitals, much better at testing people to see what they are sick with. So we have big respiratory viral panels that are drawn on a lot of patients, because that's become important to know what they're sick with. So in many ways, I think it's gotten healthcare to take this threat more seriously, because the last pandemic in 2009 with H1N1 wasn't very stressful to hospitals. It was for a little bit of time, but not like this. So I think now we see hospitals really taking this more seriously, but still probably not seriously enough.
Clearly not knowing what we were getting into 4 years ago. It's understandable where we had this one-size-fits-all approach where we were seeing these uniform social distancing mandates and standards and masking. And then I noticed as we saw things flare up, whether it be Delta or Omicron, it became more of a regional, more of a targeted approach to it. And I feel like that's what we'll see going forward if we see flare-ups, if we see these increases. Is that right to look at it that way?
Yes, and it should have been targeted from the very beginning. But you have to remember, we had horrible testing constraints, so we had no idea who was getting infected and how they were getting infected. And you had hospitals going into crisis in places like New York City, which panicked a lot of governors, which then led to blunt tools. But yes, this should have been something that should have been precision strikes to target the virus where it was infecting people. But we couldn't do that because we were really flying blind. And the other point is, January, February, half of March, there was nothing done. It was basically kind of evasion. And then when things started to get bad, that's when people started doing things. But a lot of that time had elapsed without proper infrastructure being put into place. So we got the pandemic we were destined to get.
One thing that has come up quite a bit, and especially people who were infected early on, are the effects of long COVID. And we know the government is investigating this. They're doing research into this. How real is that concern for people who may contract COVID-19, the strain that we see now and maybe in the next couple of years?
So the bulk of long COVID occurred when people got infected before they were vaccinated with the original version of this virus, or maybe Delta. Less common with Omicron, less common in vaccinated or immune populations. So yes, it still occurs, but it's less of a concern than it once was. And I think that's a testament to the immunity in the population. But this is still something that we're just kind of in the infancy of learning about, trying to understand what's going on physiologically with people who have long COVID. And this is going to be something you hear about for years to years to come.
Yeah, no doubt about that. All right, Dr. Adalja, thank you so much for this. I mean, clearly a lot of questions people still have, but we are through the storm, and I think we're much wiser for it.
Thanks for having me.